Okay, so coming to the topic proper, so liver diseases, which can broadly be classified as acute liver failure, chronic liver disease, liver tumors, and metabolic liver disease. So, what is acute liver failure? It means a person who is perfectly fine, suddenly his liver fails. For example, a patient who has taken poison like paracetamol poisoning, and we in our area, in and around area, we see a lot of patients consuming rat poison, and then they come with acute liver failure. So in a patient who is perfectly fine, whose liver is perfectly fine, because of some cause his liver suddenly fails, we call it as acute liver failure. What is chronic liver disease? This is a disease in which there is a slow damage of liver for a very long time, and the liver is chronically damaged. And then we have some patients with liver tumors. Most common is HCC, but we also see other tumors. And then the other variety is metabolic liver diseases. For example, you have Wilson disease, hemochromatosis, all those things. So these are the four broad classifications of liver diseases. And in fact, these are the indications for liver transplantation. So most of us, like, we use cirrhosis and chronic liver disease interchangeably. So what is cirrhosis? I think many of the MBBS students who are here already know, if you have read pathology, the cirrhosis is defined as end result of wide variety of chronic liver diseases. And histologically, what we can see is fibrosis, loss of normal architecture, and regenerating nodules. So this is a hallmark of cirrhosis histologically. So it's very important to remember this. It can come as an MCQ also. So fibrosis, and once because of fibrosis, the normal architecture of the liver parenchyma is lost, and then the remaining liver tissue tries to regenerate. But because of these fibrotic bands, the regeneration is irregular and in nodular pattern. So this is the hallmark, histological hallmark of cirrhosis. What happens if somebody has cirrhosis or chronic liver disease? So it reflects in human body as portal hypertension and progressive hepatocellular dysfunction. So what does this mean? So we know that all the blood in the abdomen passes through the liver, like all the blood from intestine and spleen, everything, it goes into the liver through portal vein, and then through liver filters and does a lot of metabolic function, and that blood finally drains into the IVC, and from there it enters the heart. But whenever the liver is damaged, so the blood cannot freely flow through the liver parenchyma. So that's when we have condition called as portal hypertension, because the blood is not able to freely flow from portal vein through the liver into the IVC. There is a back pressure change, and we call it as portal hypertension. And secondly, progressive hepatocellular dysfunction is the liver itself kind of slowly fails, and because of that you will have jaundice, you have hypoalbuminemia, you will have hepatic encephalopathy, you have ascites. So these are the clinical manifestations of cirrhosis. So how do you know somebody has cirrhosis? Because histological diagnosis is like cirrhosis is histological diagnosis. The two things which will manifest clinically is portal hypertension and progressive hepatocellular dysfunction. And portal hypertension will present as upper GI bleed or melena, and this bleeding is basically from varices, which is the most common cause of death in patients with chronic liver disease. So coming to what is the common etiology for chronic liver disease? So we have alcoholic liver disease, which is pretty common in our country, and it is pretty common worldwide. So there are people who drink a lot of alcohol, and then some of them will end up in chronic liver disease. Alcohol is hepatotoxic, and then we have chronic hepatitis B and hepatitis C infection, which causes chronic liver disease. But nowadays we have chronic hepatitis B vaccine. So as a part of national immunization program, all the children are administered hepatitis B vaccine. So the incidence of hepatitis B is slowly coming down, and with time I think it is going to disappear. Hepatitis C, recently hepatitis C medicines have been come into the market, and they give very good clearance from hepatitis C, and many patients are totally cured of hepatitis C. So with time, hepatitis B and hepatitis C are going to slowly disappear, and then what is coming in a big way is NASH-related cirrhosis. So we call it as fatty liver. Somebody who has a fatty liver, if the fatty liver persists for a longer time and liver is too much fatty, then some of them will end up in NASH. non-alcoholic steatohepatitis. That means this fat starts damaging the liver in some of them, and long-term damage will cause chronic liver disease. So NASH CLD, NASH-related CLD is something which is rapidly increasing. The other thing we need to remember is the patient with NASH, as I said, are at risk of chronic liver disease, but there are patients with NASH who are also at risk of hepatocellular carcinoma. So a patient can have fatty liver and land up in hepatocellular carcinoma. So this is what we need to remember. So all of us have to make sure that our liver is healthy, and same has to be conveyed to the patient. The other uncommon etiologies are primary biliary cirrhosis, primary sclerosing cholangitis, Wilson disease, hemochromatosis, as I said, the metabolic diseases. We do see good number of patients with Budd-Chiari syndrome, which is more common in northern Karnataka and southern western Maharashtra. So that's where we see patients with Budd-Chiari syndrome. And then other causes like polycystic liver disease, amyloidosis. These are the rare indications for liver transplantation, since these cause chronic liver disease. So how do we treat cirrhosis? So the only definitive therapy, only curative therapy is liver transplant. Okay. So we need to remember, if somebody comes and asks you, so what is the curative treatment for cirrhosis? Is transplant. So it should be very clear. Everything else is just going to prolong the life. It is not going to cure. For example, you might have seen, whenever you see patients in OPD, if they have varices, you put them on beta blocker. If they have ascites, you put them on diuretic. If they have any kind of infection like spontaneous bacterial peritonitis, you put them on antibiotics. To prevent development of hepatic encephalopathy, you put them on laxatives. And sometimes some people use choleretics, but they are not too much useful in majority of the chronic liver disease patients. So this is a medical therapy for chronic liver disease patient. But we need to remember, this is only to deal with complications. They don't cure the original disease. They don't cure the cirrhosis. The only thing which cures cirrhosis is liver transplant. Other than that, some patients have to undergo invasive procedures like that. For example, if they have varices, we'll band them. If there is a patient with low MELD and if he has intractable ascites, we do tips. So these are some intervention procedures which can be like BRTO and EVL, EST, like endoscopic variable ligation, endoscopic sclerotherapy. So these are the procedures which we generally do for patients who have either variceal bleed or ascites or intractable ascites. But we need to remember the definitive therapy for chronic liver disease is liver transplantation. So why do we do liver transplant in chronic liver disease? So a patient with chronic liver disease, okay, he can survive without any therapy for 10 to 15 years. Okay, provided he is still compensated. You can see a patient who on ultrasound has chronic liver disease but has no symptoms because of that. So he can live for 10 to 15 years. But then these patients sometimes land up in decompensation. Decompensation means there is acute insult to the liver, and because of that, liver function suddenly deteriorates. And that's how they present with acute onset ascites, fetal edema. They can present with HRS. So once patients starts having these symptoms, we call it as patients is getting decompensated. So once they start having decompensation, they will survive for 3 to 5 years, maybe lesser than that. So the moment patient starts decompensation, you should tell them that it is better to undergo liver transplant. If you wait, then you will not survive longer. So this is what we need to remember. So what are the complications of cirrhosis? I briefly discussed about this in previous slide. So the patients can have recurrent variceal hemorrhages. Okay. Then the patient can have ascites, they can have SBP, spontaneous bacterial peritonitis. That means the patient's ascitic fluid will get infected. Okay. And then they will have hepatic encephalopathy, hepatorenal syndrome. Because of the liver problem, the creatinine starts rising. Hepatopulmonary syndrome, because of the liver problem, there is pulmonary issues in these patients. And portopulmonary hypertension. Because of portal hypertension, the pulmonary hypertension also starts manifesting. So these are the broad complications of cirrhosis, and most common of them is variceal bleeding, ascites, SBP, and hepatic encephalopathy. We see these complications very frequently, and whenever you see these patients in your OPD, you have to make sure that you rule out all these complications, and if they have this complication, it has to be treated emergently. Because any patient, since if the patient has this complication, it means that he is decompensated already or he is going to decompensate. So the patient has to be admitted and treated aggressively. Otherwise, the mortality risk is 30 to 50%. So if you don't identify these complications and don't treat it well, there is chances of 30 to 50% mortality. So be very careful if you see a patient having this symptom. Don't miss it. Okay. So as I said, varicose bleeding, if somebody has varicose bleeding, then 1 year survival is 60%. Okay. Like 40% will die. Patient has uncontrolled ascites, 50% will die in 1 year. If patient is having SBP, 40% will be alive at the end of 1 year and 60% will be dead. If patient is having hepatic encephalopathy, 35% of the patient will be alive and remaining will be dead at the end of 1 year. And if patients had hepatic hepatorenal syndrome, if the kidneys are involved, then within 1 year, everybody will die. Okay. So we need to know majority of the patients who start having complications will die at the end of 1 year. So if you do transplant, the 1 year survival is 85 to 90%. So whenever a patient comes to me and moment I say transplant, they say, sir, can you treat it medically? Then I tell them this. See, if we treat you medically, then the chances of survival is 10%. But if you undergo transplant, the chances of survival is 90%. So you choose what you want to do. So this is what we need to understand. This is very common tendency because nobody, even any one of us has any problem and there is a medical therapy for it and surgical therapy for it. We will always choose medical therapy. Nobody wants to undergo surgery, but there are conditions in which only surgery can help you. Medicine cannot help you. It's like you have a fracture, then you have to treat it surgically or put a cast. No medicines will help you unless it is like a hairline fracture. So we need to understand that there are many diseases for which only surgery is the option. And if you delay having surgery or if you delay having transplant in this condition, then you will not make it. You may die. So this is what we need to understand. So who needs a liver transplant? So if there is a irreversible liver disease and the life expectancy is less than 12 months with no effective medical or surgical remedies to transplantation, this is the indication for. I'm going to talk more about this. And then progression of a liver disease that will predictably result in a mortality exceeding transplantation. We need to know that mortality is around 10% during or after liver transplant. So whatever you are doing, you have to outweigh that mortality risk. Otherwise, if you do a liver transplant in a patient who is a low MELD, who without transplant who could have survived for 3 years, and if he dies immediately after transplant, then you have failed in your intention. So we need to remember that. And then after transplant, we need to give a good quality of life. Because of chronic liver disease, the patient's quality of life is very poor. Then it is an indication for transplant. This can happen in patients with polycystic liver disease. Okay, some patients, the liver functions are well preserved, but the polycystic liver is so big, the quality of life of the patient is compromised, and that can force you for liver transplantation. So these are the 3 broad indications for liver transplantation. So what are the objective scores? So this is a CTP score. You might have heard CTP score. So this is partly objective and partly subjective. We see serum bilirubin, we see serum albumin, INR, ascites, and encephalopathy. And then we say child A, child B, and child C, depending on the scores. If somebody has child A, he means that he is not very sick. And then if somebody's child score is very high, 10 to 15, then those patients are very sick. That's what we need to remember. So timing of transplant. So based on 3-month mortality, patients who are child A, the mortality is like 3-month mortality is like 4%. But if the child score is like 13 to 15, the mortality, 3-month mortality is 40%. This is what we need to remember. So when we do transplant, when the CTP score is more than 10 or the CT score is 7 and patient has other complications like refractory ascites, recurrent SBP, unresponsive varicose bleeding, HRS, and intractable proliferasis. So this is where we decide that either the CTP score is more than 10 or CTP score like more than 7 with any of the following complications. That's when we decide to transplant the patient. So CTP score, as I said, it has objective components and subjective components. So that's why we have a new scoring system which is widely used now. It's a MELD score. So model for end stage liver disease score. So it's a very complicated score which basically uses serum bilirubin, INR, and serum creatinine. And this scoring, basically, if you try to do it yourself, it's very difficult. But you can do it online. You have a lot of apps in which you can calculate the MELD score, or you can do it online on the website. So that's where you use, and then you calculate the MELD score. If you want to do it manually, it is very difficult. It's not possible to do it easily. In this, you can see that the MELD score and mortality correlation. If you have MELD score of 15, you can see that the 90-day mortality risk is 20%. And if somebody has MELD score of 40, then the 90-day mortality risk is 100%. So if somebody is MELD 40 out of 40, they are at very high risk of mortality at the end of 3 months. So this is what, like we say, the sickest patient is MELD 40 out of 30. And when do we do transplant? If somebody's MELD score is more than 15, that's when you can list them for transplant. That means that if somebody's MELD score is less than 15, the risk of transplant outweighs the risk of medical therapy. But if MELD score is less than 15, then you can still manage them medically because the mortality of transplant outweighs the medical management. So we need to know that. So MELD score is 15 is a watershed line. When the score crosses more than 15, that's when you recommend transplant for them. It is less than 15, then you can wait. But then there are patients of HCC, hepatocellular carcinoma. For them, even the MELD score is low, but if they are not resectable, transplant is the only option. Then even if their MELD score is less than 15, you can transplant if they have HCC. But many a times we see that we try to tell the patient that undergo transplant, but they don't listen. They try to like use herbal therapy, Ayurvedic therapy. They will visit temples. They will go to 100 people just to avoid transplant. And finally, they become very sick. And that's when they come and tell, sir, you do transplant now. But then when patient is so sick, then transplant is not possible. It's a futile exercise. We can still do it, but the risk of mortality is very high. So it's very important for all the patients and family to understand to have a transplant at a good time rather than waiting, and patient becomes very sick and unfit for surgery. So as I said, what are the indications for transplant? DCLD, that is decompensated chronic liver disease, either CTP score more than 10 or MELD score more than 14, HCC, and then other indication is acute liver failure, or we sometimes call it as fulminant hepatic failure. So there are Milan criteria for deciding on which patients will benefit of. See, if there is a patient who has a very aggressive, very large HCC, there is no point in doing transplant because it may recur. So how to decide who is a good candidate and who is not a good candidate for transplant? So one of the criteria is Milan criteria. If somebody's HCC is less than 5 centimeter, or he has less than 3 lesions and none of them are more than 3 centimeter, those are the indications for liver transplantation. If the size of the lesion is more than 5 centimeter, or if you have more than 4 lesions which are more than 4 centimeter, then probably those patients will not benefit from liver transplant. This is Milan criteria. But then nowadays we are like more and more expanding those criteria, and more patients are being accumulated for transplant. Size alone should not be taken as criteria. We should also include the tumor biology. So a lot of research and a lot of changes are going on. These are some other criteria which is more liberal than Milan criteria, that is UCF criteria. All these criteria can be asked during your entrance exam or your theory questions. This can come in as your like MCQ or theory question. So what is fulminant liver failure? It is like similar to acute liver failure, which is much more rapid. When we call it as fulminant hepatic failure or fulminant liver failure, the patient presents with sepsis, MODS, and then these patients will have brain edema. Brain starts swelling because of the toxic products accumulating in the blood. So how do you decide which are the patients who will need transplant? Because there are some patients with acute liver failure, they can recover on their own. So everybody with acute liver failure may not need transplant. But which are the patients will need transplant and which are the patients of acute liver failure doesn't need transplant? We use King's criteria. So we separate one for paracetamol poisoning and the separate one for non-paracetamol poisoning. So I don't know, for you people it will be difficult to remember, but I'm not sure whether they are asking this to your MCQs in your entrance examinations or in your theory exams. I'm not sure. So coming to what are the types of liver transplant, broadly we have, I think all of you know that there are broadly two types of liver transplant. One is deceased donor liver transplant, and then in which more common is brain dead donor. Somebody's heart is beating, but brain is permanently dead. So those are the patients who donate their organs. We call it as deceased donor liver transplant. And sometimes there are the patients in which the family members donate half of their liver to their loved ones, to their relatives. We call it as living donor liver transplant. So there is always a conflict between DDLT versus LDLT. So if you go to West, Europe and America, so a lot of organ donations are happening there, and that's when the number of living donors happening there is less. But if you see in Indian scenario, the organ donation is less. So that's why we see more and more living donor liver transplant being conducted in India or in Asia Pacific region, even in Middle East. So we need to know that. So DDLTs are more common in Western countries, and LDLTs are more common in Eastern countries. Coming to what are the advantages of DDLT, there are no donor issues because the donor is brain dead. It is a shorter, smoother, and easier operation. It is the liver fails, and you can retransplant provided you get a new liver. The disadvantage, as I said, the donors are less in India. A lot of patients have to wait for a long time to get a liver, and many of them die. The waitlist mortality we say is up to 50%, and it's always in emergency. Like always, DDLT will happen in the middle of the night. So this is how we do it. We take out the diseased liver and put the new liver. So I remember there was one MCQ was being asked, in which order you do anastomosis when you put a new liver. So you first do the caval anastomosis, then you do the portal anastomosis, then you do hepatic artery anastomosis, and finally you do the bile duct anastomosis. This was the MCQ which was used to be asked commonly. I don't know now they are asking this or no. But then, as I said, the first anastomosis to be done is IVC. The second one is portal vein. The third one is hepatic artery, and the last one is the common bile duct anastomosis. So you can see this, how the damaged liver looks, and then you have put a new liver in the deceased donor liver transplant. You put the whole liver, unless you are splitting the liver and using the left lobe for a pediatric patient. So I am pretty sure you know these liver segments. So there are 8 segments. So the left lobe consists of segment 2, 3, 4, and the right lobe 5, 6, 7, 8. So and then segment 4 is segment 4A and segment 4B. I still remember when I gave all India exam, so they had asked whether the segment 4A is on the top or segment 4B is on the top. So like this was one of my entrance questions, the liver segments. So it's a separate topic actually. The anatomy of liver, I can talk about it sometimes in future. I already have a lecture prepared for it. But then you need to know in detail the liver anatomy, especially if you are interested to do a GI surgery or liver transplant. So then you can see that whenever we are planning for a liver transplant, this is what we study: the hepatic artery, portal vein. We need to know all these things. Then we study the hepatic venous anatomy, the right hepatic vein, middle hepatic vein, left hepatic vein. Many of you here may not understand these images. If you start working in this field, you will understand all these images, and then it is very important to study these images before starting the surgery or selecting the patient for surgery. And this is what we look for, like how, because when you are doing liver transplant, you have to make, like, you are not discarding the other part of the liver. The half liver which is left with the donor has to be well preserved and has to function well, and the other half you are going to put it in the recipient, that also has to work fine. So we need to understand this. So it needs a lot of planning when you are doing living donor liver transplant, and this is a venous drainage anatomy, very important to study well before planning surgery. So this is how it looks at the end of transplant. So advantages of living donor liver transplant: it's a planned operation. You can optimize the patient. You can choose the good donor and good quality graft, and then there is no waiting period. You can just, if there is a donor in the family, you can right away do it. But then what are the disadvantages? Because you are taking a liver out of a healthy donor, so risk of complications, and it takes long time to learn for the surgeon. The training opportunities are not there nowadays. It's better than before, but still opportunities are limited. And then multiple skill sets are needed, and it's a teamwork. You need a big team to do liver transplant, living donor liver transplant. The overall survival after liver transplant, I said, is 90% at the end of 1 year. We still lose 10% of the patient. If there is a high volume center, the results are excellent. Hospital mortality is 9 to 10%. You have to explain to patient. It's very important. Can't say that 100% results. Results are 90% and mortality is around 9 to 10%. And survival is more than 85% at the end of 1 year. So the results of liver transplant has improved. As Dr. Kishan was saying initially, that the outcomes are better and better. Why it has improved? Because we do good patient selection, we do donor selection, we optimize the patient, the imaging has improved. Nowadays, we have very good quality CT scans, MRI, which we can plan very nicely. The operating skills of the surgeons have improved. We have better anesthesia and ICU care facilities. We have very good immunosuppressive medicines, and we strictly follow these patients. As I said, what are the improvements in imaging? Like we have a spiral CT, and then we have MRCP, and we have intraop Doppler also. What are the improvements in anesthesia? Like the ICUs and ORs, like it's now they have become synonymous. And then there's laminar flow is the sterility is strictly maintained. All kind of latest investigations are being used in liver transplantation. So what are the issues which we are dealing with? Is paucity of organ donation. Like slowly the organ donations are increasing, but still there is lack of awareness. A lot of traditions and belief, we say, like Moodanambikes, and then extended family members inhibit patients from or family from donating the organs, and there is always some mistrust with the medical system, potential donors and their families. Will this change? Yes, definitely things are changing. More and more people, more and more families and patients are coming forward for organ donation. What are the future challenges for all of us to increase the organ donation? And the cost is too high currently for liver transplant. We have to bring down the cost. Many of the insurances, especially alcoholic patients, the transplant costs are not covered. And then many of the patients in India don't have insurance coverage. So we have to broaden insurance coverage. And then we should have a national registry for CLD. Good work has been done in maintaining a national registry in the last couple of years, but we need to publish the data also. So these are a couple of success stories which we did. This transplant we did during the peak of COVID time, and this was a MELD 40 out of 40 transplant. Young patient came with INR of 5. We had to do a couple of plasma exchanges, and his brother came forward to donate. We kind of prepared him quickly for surgery, and then patient did well, and now he is still doing fine. So this is the other patient. This is a Wilson patient, identified later in his age, and his mother came forward to donate, but they did not have money, so we did a lot of crowdfunding, and then finally we did the transplant. Patient is doing fine now, and then we did a first living donor liver transplant in a medical college. We did it in JSS Medical College. This was done at no profit, no loss basis, and patient is doing fine. Mother donated for child. Then we have done liver transplant for the heaviest person in India, 160 kilo patient. So these are the couple of risky surgeries we did, and then a couple of publications from me. Like this is we see a lot of patients who are frail, or we call it as sarcopenic patient. Their muscle mass is lost. So in this study, what I tried to see is whether there is any relation between long-term survival of the graft with the fat accumulation in the muscle. And these are the first studies to show that there is association between the graft survival and fat accumulation in the chronic liver disease patient. So, and then this is what we published in Liver Transplant Journal last year. So this is a multicentric study, including our hospital, that how we did liver transplant during COVID time also. So we have detailed our experience and how we did it, what precautions we took during COVID time. So that's it from my side. So kind of made it brief, and if any of you have any questions regarding liver transplant, I would like to answer it. So try to be like more interactive rather than just slowing the slides.
Members, take this opportunity to directly interact with the authority himself. Okay, any doubts or queries regarding not just liver transplant, as such he is a specialist in entire gastroenterology. So any queries or any doubts you have regarding the subject, you can directly ask with him. Okay, those who are watching in YouTube can directly post your queries in the chat section. We'll try to answer them. Sir, it was a really a wonderful session. You made it very short and sweet. Okay, you kept it what is really essential and our day-to-day practice and what we should really know, that you have explained us nicely. And thank you for that. Shweta, are there any questions in YouTube?
No, sir.
Okay, members, please go through the topic once again. The lecture after lecture, you can again go through the books. Okay, if you find any questions or if you find any doubts regarding the same, you can feel free to post them in the YouTube chat section, or you can directly mail to us. We'll forward it to sir and we'll get the appropriate answers from him. And hopefully we'll also have some more sessions related to the specialty by sir, our Sunil Shenvi sir. Glad that he agreed to take a class for us. We really feel it's so happy today amidst his busy schedule. He's a very popular surgeon in Bangalore. Okay, so amidst, like he already mentioned in the beginning, along with surgery, he's also a medico-legal consultant as well. So that shows his interest to learn more and to help more people. So thank you so much, sir, once again for being with us.
And there is one question: is patient with 5 cm HCC lesion can have liver transplant? Yeah, definitely. So, but then see, transplant is the last option. So, patient with hepatocellular carcinoma, we have other modalities also. So we can resect if somebody who has very liver is not very bad or HCC occurs in a non-cirrhotic setup, then we can always do resection. So if the patient is child B or child C, or the anatomy is as such that it is not resectable, then we can definitely transplant them. And nowadays, like we have such good therapies for HCC. There are patients, initially we feel they are not resectable, then we downstage them by local regional therapy, or we use immunotherapy. And then if the disease is good, then patients can undergo liver transplant. And we do routinely, like many patients undergo liver transplant for HCC. So yeah, TACE is, as I said, local regional therapy. TACE can be as a bridge for liver transplant. So for example, if you have a patient who has a 5 cm tumor, you TACE him and wait, see whether some more lesions appear or tumor regrows. And the other thing is, if the patient has portal vein thrombus, then TARE is better than TACE. So TACE and TARE. Then we have other things, radiofrequency ablation, microwave ablations. So HCC itself is like, I would say, for example, I will be happy to take a class on liver anatomy, detailed liver anatomy, and then how to approach a patient of HCC. Like it's a vast subject, HCC. Like we have started.
What's the role of sorafenib, sir?
Yeah, sorafenib is like one of the kind of very good therapy now. But then sorafenib is something which was old. Now, like we have lenvatinib, and now we have newer immunotherapies coming. Now we have bevacizumab and acetylzumab, which has come.
Yes, sir.
Then we have novolumab. So there are a lot of newer immunotherapies. Sorafenib is one of the oldest, which I would say it was the first immunotherapy which came in. But now the therapy is much more advanced. And now we have a lot of newer medicines which we use, like lenvatinib, which is better than sorafenib. And then nowadays we are using immunotherapy like bevacizumab, atezolizumab, which is giving good results in many patients. So like it's a vast field, and we have made a lot of progress in that field. So HCC itself is a big topic, and then definitely HCC and liver transplant, it can be like 45 minutes class. So it's a vast, but then Yeah, HCC transplant. Yeah, it's like now we are very, very liberal.
Sir, as we know that there is a huge demand for liver transplantation, starting from the small kids to the patients with CLD or HCC. But
Yeah.
what about the awareness about liver donation, sir? Liver donors.
No, nowadays there are very good awareness also, because see, I think there was every month there is one donation happening in Bangalore. Last few months in Hubli, Dharwad, regular donations are happening. Bangalore donations are happening regularly. So awareness, if you see, I came to India in 2017 from US, and this is 2022. 5 years is lot of awareness. Number of organ donations have gone up, and this year we are already doing, like, we have already crossed 100 donations. So things are rapidly improving, and there's a lot of scope to improvement also, but things are getting better. So one more
What is
question: after transplantation, should we undergo chemotherapy? So that's a tricky question. So after transplantation, for HCC, we'll put them on mTOR inhibitors, because they also have effect on they inhibit the tumor group. mTOR inhibitors. They are immunosuppressant also. So most of the patients we put it, but then it's unusual for somebody after transplant we give chemo, because generally we don't give it after that. We have to give it before that. Make sure that absolutely make sure that, like, you can be absolutely sure, but reasonably make sure that the disease doesn't want to come back after transplant, because you do transplant and the disease come back, then obviously you are not right in doing transplant. But it's very difficult to judge in spite of because biology is unpredictable, but still you have to reasonably make sure that the disease doesn't come back after transplant, because otherwise if the disease comes back, your decision is wrong. Obviously if the disease come back, then you will end up giving chemotherapy and all, but decision for transplant was probably wrong retrospective. So mixed HCC and cholangiocarcinoma need transplant. Yeah, a lot of trials are being done, but still not standard of care and high risk of recurrence. So there is a strict protocol. For example, for cholangio-CA undergoing liver transplant, there's something called as Mayo protocol, in which they give neoadjuvant chemo, radio, and then make sure that tumor biology is really, really good, the favorable response. Then only you transplant them. Otherwise, if the tumor biology is not good, then probably you should not transplant. Same with mixed HCC.
So there's a doubt from YouTube. What are the infection risk post-transplant, sir?
Sorry, I could not hear you.
What are the infection risk post-transplantation, sir?
See, in post-liver transplant infection, we don't use very heavy immunosuppressant in liver transplant patients. So infection risk is there during transplant, immediately after transplant. Okay, and as long as patient stays in the hospital. Once the patient is out of the hospital, getting discharged, the risk of infection drastically comes down. And once they are out of the hospital, maybe 2-3 months down the line, the risk of infection is very, very less. It's not like always their patients are worried the risk of infection. Yeah, definitely they are at the higher risk than normal people, but it's not so high that patients should be very much scared. But they have to take proper care after transplant. They should eat clean water, not go to crowded places, and then eat at home, clean food. All those things they have to follow. But immediately during transplant and immediately after transplant, the risk of infection is quite high, because patients with chronic liver disease are very at high risk of infection. The immunity is very low. But once the transplant is successful and patient walks out of hospital, the risk of infection drastically comes down.